My today's research topic for presentation is to test the validity of a questionnaire, that is an infant gastroesophageal reflux questionnaire, using a modality called combined multi-channel intraluminal impedance pH monitoring. So now to understand this, we first need to understand what is gastroesophageal reflux disease and what is gastroesophageal reflux. Gastroesophageal reflux is involuntary passage of the gastric content into the esophagus, but it is a completely normal physiological process. It is mostly asymptomatic, may occur multiple times a day, but it is usually of short duration, occurring mostly after a meal. And when this GER causes troublesome symptoms with or without complication, it is called GERD. Now we have certain modalities available to diagnose GERD. 24-hour pH study is said to be the gold standard currently. But in recent studies, we've found that it is only 63.2% sensitive. Whereas we have another modality called combined multi-channel intraluminal impedance pH monitoring, which is 80.8% sensitive and in a lot of ways superior to just the 24-hour pH monitoring. Now, how is it superior? By doing that test, you will know about the chemical property of the reflux, whether it is acidic, alkaline, weakly acidic or weakly alkaline. It will also tell you about the physical property of the reflux, whether it is a liquid, gas, or it is a mixed reflux. It will also tell you the extent of the reflux in the esophagus, and it will also tell you the direction of the flow. So that is something that helps you differentiate between a reflux and a swallow. It will also tell you about the bolus clearance and acid clearance. Now, we have tried to validate a questionnaire, so let's know a little bit about its history. It was devised in 1996 by Ornstein. It had 161 questions, which was way too much. So ultimately they modified it, and the one that we have used here is an 11-item questionnaire which accumulates to 25 points, that is the IGERQ score. So the aim of the study was to validate this questionnaire as a clinical aid in diagnosing GERD using the modality called MII-pH monitoring in Indian children. So it was a cross-sectional study performed from December 2017 to June 2018. We included infants in the study with symptoms suggestive of GERD, esophageal as well as extraesophageal. So they were vomiting, regurgitation, recurrent LRTI, unexplained cough or wheeze, and neurologically impaired children with symptoms suggestive of GERD. We took a detailed history of these children. These children were then clinically examined, and they were then finally exposed to the interview, the questionnaire containing 11 questions, and they were graded out of 25 points. IGERQ score of over 7 was considered to be positive. And then finally all the children were subjected to 24-hour pH impedance monitoring using a device called Omega. The catheters that we've used were 7 impedance and 2 pH sensors. We calibrated these catheters prior to the use in acidic and alkaline pH. The position of the catheters in the infants was determined using a formula called the Strobel formula, but the final position, however, was determined on the X-ray. And then the parents or the caretaker, they were explained on how to use the device, which buttons to press when, and also how to maintain a diary with it simultaneously. So we diagnosed GERD on the combined MII pH monitoring using a certain scoring system and different modalities. That is, reflux index of over 5.1 was taken to be positive. The Boy-Oika score of over 11.99 was taken to be positive. And we also assessed the symptoms of these children based on certain parameters, like a symptom index of more than 50 was considered positive. The symptom sensitivity index of over 10 was considered to be positive. And SAP, that is the symptom association probability of over 95 was taken to be positive. Now, we had taken 13 children, 6 boys and 7 girls. Their average age at presentation was 7.5 months. The duration of their symptoms was 4.7 months, and the mean time of recording on Omega device was approximately 23 hours. Main symptoms that we found were poor weight gain, followed by vomiting, recurrent cough, irritability, and regurgitation. Now, in our study, we found that 5 out of 13 children had GERD, and their Boy-Oika score was also positive. 7.6% children had a positive SI, 15.4% children had positive SSI, and 23.7% children had a positive SAP, and a reflux index of more than 5.1 was observed in 30.8% of the children. Out of 5 children who were diagnosed to have GERD, 80% of them had failure to thrive, 60% of them were found to be fussier than normal on the IGERQ, and only one of these 5 children presented to us with extraesophageal symptom of recurrent pneumonia, that is more than twice in 1 year. Now we found a positive IGERQ score of more than 7 in only 5 children, and out of these 5, 3 of them were diagnosed to have GERD on combined multi-channel intraluminal impedance pH monitoring. We also compared different parameters of the combined multi-channel intraluminal impedance in both the groups, that is the positive IGERQ and the negative IGERQ, and we did not find any stark difference in the statistical values. So in a nutshell, a positive IGERQ of more than 7 had a fair correlation with the diagnosis of GERD on combined multi-channel monitoring, but the sensitivity was and positive predictive value was 60%, the specificity and negative predictive value was 75%. So I would say that though the correlation was fair, the low sensitivity and specificity is a limitation. It may be the best diagnostic modality that we have currently, but due to its limited availability in India and cost of investigation, which is way too high, we still have the need of a clinical aid to diagnose GERD.
Thanks very much for a very clear presentation and for taking an audience which may not be so experienced it through the history and a little bit of the explanation. So well done on doing that. So you started off a little bit by talking about the sensitivity of
Yes.
pH impedance and pH studies.
Yes.
And you talked about the gold standard and a superior one, but how was the sensitivity of those two assessed? How did you give a sensitivity of 80%?
So based on a study that was done, it was
But what's the 100% accurate test? What's the 100% accurate? What's the real gold standard that you base those against?
So against the real gold standard currently, so that is what we are struggling with, because all the modalities available are not very accurate in diagnosing GERD.
But you quoted that impedance
Is
was
80 point
80%.
almost, yes. But it also
Did you
has
do endoscopy on those, for example? Was endoscopy done?
No, sir. Endoscopy wasn't done because on endoscopy we thought we'll only find cases which have complications. GERD without complications, we may not get anything on the endoscopy. So they were only subjected to the combined multi-channel intraluminal impedance, and the scoring was done for all the children.
Okay, I'm just pushing you a little bit because, of course, I'm asking you a question which no one can really answer in terms of true gold standard. You talked about one patient having a complication of pneumonia.
Yes.
In that patient, was there evidence of proximal extent of reflux?
No, sir.
So why did you attribute the pneumonia to the...
No, sir. Actually, that child had an evidence of, as the pneumonia that we saw, both the times had aspirational pneumonia. So yes, it had the evidence of proximal this thing, but the IGERQ score in that child was negative. It was below 7. It was an IGERQ score of 5.
And was that child neurologically normal or neurologically?
The child was neurologically normal.
He was normal. So it could be aspiration, though, or it could be reflux.
It could be aspiration or it could be reflux, yes.
Okay, so where would you take this from now, then? What's the future hold for this piece of work? How would you carry it
so
forward?
I'd like to, if possible, I'd like to, one thing that I've found in this study is the children who were presented with the extraesophageal symptoms were somehow not fitting on the IGERQ score. So I think that is one drawback, because here we find a lot of children who complain of reflux and they also show up with recurrent pneumonia. So maybe we need to also look at the extraesophageal symptoms on the IGERQ.
Okay, simple question, simple answer. So the simple question is, this questionnaire, who conducted the questionnaire, who filled the questionnaire, and Was the same person involved? What? We didn't get that information.
No, sir. It was either myself or my colleague who filled the questionnaire, and all the readings were done by me and confirmed by my guide.
Thank you.